So when we left before the break, I left it pretty bleak, talking about all this disease. And I had a couple of students that asked, okay, so should I just go get like a scan? You know, now I'm like really worried. Maybe I should get an angiogram. Or, you know, how do you know that you have these diseases? I mean, if you can't, you can't really scan yourself and see them. So what would this look like? Well, in this classroom, you're all at low risk because of your age. Okay? Believe it or not, I'm still at low risk because I'm not past an age group where you become high risk. What is that magic number? Well, in some cases, it's over 60 years of age. If there's family history, it might be 50. Okay? If you're 65 but physically fit, you don't have high blood pressure, you've never smoked, okay? Your cholesterol levels are normal. Let's talk about cholesterol, for example. We talked about hyperlipidemia. So HDL and LDL levels. You guys know what those stand for? So what do they stand? What's HDL? High density lipoprotein. What does high density lipoprotein do? What's that? It binds up cholesterol and takes it where? To the liver. And low density lipoprotein, what does it do? What's that?
Brings it into the cell.
Well, it makes it available in the bloodstream, right? It takes it from the liver out into the bloodstream so that the cell can actually use it. Make sense? So when you're growing developmentally, you need cholesterol. Like when you're 7, 8, 9, 10, 11, 12 years of age, you know, you wake up and you're like 2 inches longer than you were when you went to sleep. You know? I mean, all of those cells that just were, generated need new cholesterol for their cell membrane. But once you're done growing and the growth plate's closed, you just need enough to repair. So when we're younger, you never have to monitor the HDL, LDL levels. Well, HDL is considered the good cholesterol, right? Or the good indicator, because it takes cholesterol out of the bloodstream. Well, that's not such a great thing for an 8-year-old, because you need it for cell growth. But in our age, when we're done growing, we just need enough to repair bodily functions. We're not going to grow 6 inches between now and next year, although it would be nice in my circumstance. But that's not happening anymore. LDL, so that's why you get 2 numbers. So you get in a blood draw, and they look at HDL levels, which we want relatively high, and we want LDL levels, which are relatively low. So if you are 65 years of age, if you're overweight, you don't exercise on a regular basis, you've been a smoker for the last 20 years, and your cholesterol levels are out of whack, and you've been complaining of heart, chest pain, they're going to do an angiogram. Make sense? Okay. So that's how we do these things. Or you have transient ischemic attacks, like I'm having trouble remembering my where I live periodically, but it just sort of goes away. And my spouse wants me to come in and have my head looked at. They might scan, they might do an angiogram to see what's going on. So let's talk about some of these therapies. So that little description sets us up for some of these therapies. Well, I want to show you the first therapy. Okay, I'm gonna dim this. This is an angiogram first, with an angioplasty next. It happens really fast because this cardiologist wants to get on the golf course. Okay, so this is a catheter injecting a dye, and you can see that this dye does not go down here. Does that make sense? It doesn't go distally. Now, this is a balloon. You see the 2 marker bands? So they're going to inflate the balloon right here. You see the balloon inflating? It's smashing this plaque out of the way, and now you see the contrast has reopened or the balloon reopened up the distal blood flow, and now all of this vascular network downstream you couldn't see before, now you can actually see. He's doing it again, touching it up. Opening it back up. Okay? It's that fast. Do you want to see that again? You want to see the before again?
Yes.
Okay. So, here's the before. Okay, you see how there's nothing down at the bottom of the screen? See that? Nothing at the bottom of the screen. You get that? Let's do it one more time, because you gotta watch quick. Where you're watching is actually down here. There is no distal blood flow down here. Here's the wire. You know that the vessels go down here because there's a wire in place. This is an over-the-wire technology. Now here's the balloon coming in. He goes over, he comes back, he's going to inflate right in this area. Smash that lesion out of the way. And now look at all the distal blood flow. Wasn't happy, it looks a little sparse down here. So he's going to come and touch it up a second time as a reinflate. Okay, and now it's opened back up. This is with the heart beating. That's why you're like, why is the cameraman dancing? No, that's the heart actually moving. Okay. No, there's probably music in the OR, but that's not why there's Bob in here. Okay. Angioplasty. Angiogram is injecting the dye that's radiopaque, so it shows up on X-ray. And then angioplasty is the balloon expanding over the lesion, pushing it out of the way. Okay, so now there's newer technologies that we can use.
Coronary intervention.
Hang on. That put a lead behind. So the question that was asked earlier is, now if we open this up, why don't we leave something behind so it doesn't re-stenose or reclose?
Percutaneous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. A small, hollow tube called a catheter is inserted into an artery in the groin or arm and threaded to the affected artery. A thin, flexible metal wire is then advanced through this tube and past the site of blockage in the artery. A second, smaller catheter is then inserted over the wire and threaded to the same artery.
So this is exactly what we saw
When
earlier.
it reaches the narrowed area,
But it was just a balloon.
On its tip is inflated to reopen the artery.
This
and drive
balloon
the blockage into the artery
has a
wall,
stent wrapped around
while at the
it. See?
same time stretching the artery open to
When it
increase blood flow
deflates,
to the heart.
it leaves behind the stent.
Both catheters and the wire are then withdrawn.
Make sense?
About 70 to 90% of coronary angioplasty includes placement of a stent, a wire mesh tube that holds open weakened arteries. The stent may prevent re-narrowing after an artery is widened, and it stays in place permanently as the blood vessel lining heals over it.
Okay? Questions? No questions? There's always questions after the videos. Yes?
So what kind of stress is actually put on the vessel once they do put the stent in? Is there
What kind of stress is put on the vessel when you put the stent in? That's a great question. So all of the companies that manufacture these balloons, they have tolerances to tell you how much to inflate it, in what diameter vessel, so that you don't rupture the vessel. And I've been in cases where they've ruptured the vessel. It's not pretty.
Do they do like they have to
There's a lot of bad words that get said out.
right. For the angiogram, do they do like an angiogram before to figure out like
Yes.
how wide, and then they do
Yeah.
it just for them?
Yep, that's exactly. So the question is, how do they figure out what the size is? So they'll come in with the wire. They use a guide wire. Usually come in from the groin or from the arms, usually the left arm prep. And they'll come in into the coronary circulation, put the wire in. And then over the wire, right, there's a hole in the catheter that goes over the wire. It's called a guide wire because it guides you where you're supposed to go. And why a wire? Because the wire, you can torque and you can have different tips on it. You can have like a pigtail that's nice and soft. You can have it with a right angle. There's one that's called a hockey stick where it kind of goes like this, and then you can turn it in different directions to try to get it into the different vessels that you want. And that's an art form that these guys have now. They get in there, they put the first catheter down, and they inject contrast. And they see a blush, and from the screen they can measure it's 3 millimeters in internal diameter. And then they go on the shelf and they grab their 3 millimeter diameter stent, and they read on the box, it says to inflate to this PSI with a 3 millimeter inner diameter stent, and that's what they follow. And if they go off label, they have the risk of doing bad stuff. Why would they do that? Well, you inflate, and you're watching the screen, and the balloon doesn't inflate all the way. So the doc says, I'm going to give it a little bit more. Right? Maybe 9 times out of 10, it goes, and it opens up, it's like, perfect, all right, back up, fine. But the 1 time out of 10 that it doesn't perform well is when bad stuff happens. Okay?
So when you put that stent in and it expands, what happens to all the tissue that it kind of displays? They call that necrotic tissue.
It stays.
It just stays localized and hangs out?
Hangs out, yeah. So the question is, when you put a stent up, and the newer ones now is a stent with material also, so it's called a stent graft. So if you just have a stent in place, then you still have holes. If you have a stent graft, then you've really isolated that stuff, the necrotic tissue, up against, and trapped it up against the vessel wall. Okay? So we see restenosis of reclosing, that's that word, reclosing. We see restenosis rates are worse with just bare metal stents. When you have a stent graft, restenosis rates are actually better. They last longer. And then, of course, now there's what we call drug-eluting stents. Right? So what are the drug-eluting stents? Well, it's a stent that has impregnated into it drugs that block proliferation. So like things like paclitaxel, that is an anti-proliferative. So it prevents that tissue from mitotically growing and dividing and coming in. And those are those drug-eluting stents. They're what we call DBSs.
Wouldn't how much you can inflate it depend on how thick the plaque is for?
Yes.
So, you said that they measured the vessel diameter, right? So like 3 millimeter or whatever. But then wouldn't they have to measure how much of the plaque is occluding?
Well, so they're going to measure proximally and distally to the lesion, and to get the nominal healthy vessel diameter, and they know that that's what the tissue could go to. Does that make sense?
Okay.
So they keep track of the lesion because they know the lesion, has necked it down to 1 millimeter, but I want to get it to 3. So they know, they might say, you know what, we're at 2.5. I don't want to push my luck. I'm satisfied. Let's deflate and get out. Okay? Does that make sense? So they kind of want to know what that limit is, and that's why they measure healthy landing zone. They measure the disease spot to determine how much can they push.
So, kind of continuing on what he asked, so that that necrotized tissue or that debris that was occluding, after we stent it, does it get pushed out like towards the tunica externa, or does it get like compressed into a diamond? Or
It just kind of stays in the medial layer.
But it was taking up space at one point when you kind of just like, do you just like compress it down?
Yeah, you just compress it down. I mean, you might see the tunica externa or the adventitial layer kind of bulge a little bit, but no, not much. It flattens down pretty good. The harder the plaque, the reality is if you have a really hard lesion that's extremely calcified, you can also see calcification under x-ray. They show up as white streaks. So you'll know on angiography if you have a highly calcified lesion or not. Okay? If you have a highly calcified lesion, you're probably not going to be able to go from a 1 millimeter internal diameter to your nominal 3. You're probably going to say, if I can 100% improve, if I go from 1 to 2 or 1 to 2.5, and nothing bad happens, I don't want to get greedy. I'm satisfied. Let's get out. The patient's going to feel a lot better, and we're going to call it good. So, they always say in the OR that the enemy of good is better, right? So if it's good, a lot of times these surgeons or these cath lab guys will say, okay, let's just be satisfied with that. Okay, watch, the patient will feel so much better tomorrow, and I don't want to push our luck. Okay. All right, last question, and then we'll finish up.
For instance, flexible enough for vasodilation or vasoconstriction?
Question is, are the stents flexible enough for vasodilation or vasoconstriction? Typically, no. No. So the vessel mechanics are all interrupted. All right, so the last one that we need to cover is ischemic heart disease. We talked about congestive heart failure today. We talked about arteriosclerosis. We really focused heavily on atherosclerosis with the atheroma. And now, lastly, we're going to cover ischemic heart disease. So the heart itself functions between a balance. There's this balance between how much it needs and how much it gets. And the problem that occurs with ischemic heart disease is the balance is interrupted. Meaning that the heart, you saw it during that angiogram procedure where you had the balloon come in, you saw how much the heart was beating. And that's actually under anesthesia. So the heart is working as a muscle all day long. It never stops. And the problem is with ischemic heart disease, here's another equation of cardiac output. Heart rate times ejection fraction. So the ejection fraction is the percentage of blood that's ejected out of the heart per beat. And what's going to influence cardiac output the most or challenge it is atherosclerosis. In atherosclerosis, these lesions that we looked at of the perfusion of the heart itself, the coronary circulation. So I said the coronary circulation comes right off the aorta and goes immediately to the heart. And those diameters are no bigger than 3 millimeter ID. So they might be 2, maybe 3.5, but you never see anything much bigger than that of the coronary circulation. So you're talking about a very small diameter to begin with. So if you have a atheroma that develops in a small diameter tube, the ability for you to go to a 90% occlusion happens pretty fast. That's why we have more issues with the heart and with the brain circulation with these atheromas than we do with like the femoral artery. Because if you have a lesion there, these vessels are like 10 to 13 millimeters in inner diameter. You know, they're 4 times the size of opening. And so you have a lot more space for it to narrow before you have problems. Okay? So this is showing the heart here. This is showing atherosclerosis of a vessel, the progression to a complicated lesion that means it has the opportunity to either rupture or close off blood flow completely. But as it narrows, it's decreasing blood flow to the heart itself. And what's the resulting clinical sequela? Well, we get angina pectoris, that's chest pain. We might have what we call a myocardial infarction, where we get a heart, that's a heart attack. Myocardial infarction is a heart attack. And that means that there's blood flow that's cut off to a certain area of the heart itself, and that tissue dies and scars over. If you see scarring of the heart, you know there was an MI. Now, is it possible to have a restriction of blood flow to the heart and get in and treat the patient fast enough where there's no scar that forms? Yes. And that's why now you see some of the new advertisements of these cath lab clinics is how fast. There's this one, it's either Banner Hospital or it's, I think it might be Banner Hospital down in the valley. And it's these patients that are holding these cards of how long it took before they were treated in the cath lab. You know, it's like 45 minutes, 90 minutes. They're all smiling, obviously alive, which is a good thing that they're holding the sign, right? So everyone's a success story. But now the big deal is how fast can you treat the patient? Because time is of the essence. Chronic ischemic heart disease, long term, narrowing that takes place over a long period of time, or what we call sudden cardiac death. Sudden cardiac death where the heart itself just stops. So if we look at angina pectoris, most commonly just referred to as angina, it literally translates to a strangling feeling in the chest. That's the translation. A strangling feeling in the chest. And we've got a couple of different types I want to characterize. Stable angina is pain that happens when the patient exerts themselves, like walking up a flight of stairs, going upstairs to the bedroom to get their reading glasses, and then wanting to come downstairs to read. And they get chest pain as they walk upstairs. That's stable angina. That's the most common. So that earlier scenario, when would somebody go get an angiogram or a scan? So you know what? I've just noticed lately that when I run upstairs to grab my reading glasses, like I get like sort of heartburn or chest pain. So really? Well, they're 65 years of age, right? Maybe a little bit overweight, maybe they never smoked. So you know what? I just want to do some blood tests. Do some blood tests, find out that they have high blood pressure, that's untrue, and that they're in a state of hyperlipidemia. Their LDL levels are too high. Then they say, you know what? We're going to bring you into the cath lab, and we're going to take some pictures of your heart, an angiogram. And we're going to do that, I want to do that while you're walking on a treadmill. Okay? I want to take some measurements, they put them up to electrocardiograph, get electrical signatures. They can tell a lot right there. But they're going to do what we call a stress test. And they're going to test them during stress. That's stable angina. When the patient is under an exercise or a stress condition, they exert symptoms. But when they're sitting on the couch enjoying their potato chips, clicking through the channels, no pain. Okay, that's the most common. Prinz metal. This is also known as variable angina. And this is pain at rest at night. Pain at rest at night while they're sleeping. Crescendo angina is one that there's usually a plaque that's disrupted, like an atheroma that gets disrupted, and then it lodges in the coronary circulation and it causes a shut-off of blood flow. And crescendo angina means that over a 3 to 4 day period, the chest pain gets worse. Okay, so the patient would say, you know, it's Sunday afternoon, they go to the ER because, you know what, I started feeling a little bit of chest pain on Friday evening, and I didn't think it was a big deal because it went away, and I kind of took it easy on Saturday, but Sunday morning I woke up and it was like worse, and it wasn't just periodic, it was like, and I still have it. So that's crescendo. Any musicians in the audience? What's crescendo mean? It gets louder. What's decrescendo mean? It gets softer. So crescendo angina, unstable angina is one that builds up maybe over a 3 to 4 day period of time. So let's answer this question. What type of angina occurs because of vasospasms of one or more coronary arteries, often during sleep? Often during sleep. Prinz metal. So another characteristic of Prinz metal, even though I didn't mention it, is there's a lot of coronary artery vasospasms, but you would have gotten this, or you should have gotten this anyways, because we said during sleep, and that's a characteristic of Prinz metal. Okay, if we look at myocardial infarctions, heart attacks. Well, if they're acute, then they happen over a short period of time, quickly, right? The heart itself can handle, the myocytes can handle ischemic episodes of about 20 minutes. Okay, plus or minus, obviously, depending upon the patient. But that does give us the ability to treat, and that's why treating quickly is so important. Okay, and some of you might be thinking, well, you know, in some cases it may be 20 minutes before they actually make it to the emergency department. True. Okay, but if you're not treating for hours or days, you have a bigger issue on your hands. And so let's look at that. If you take a peek at the circulation, and this dotted area is highlighted. If we have a lesion that shows up and blocks blood flow right here, and that lesion is shown right here as well, you can see the distal tissue that's highlighted in kind of this lighter shading white. That's the area at risk. That's the perfusion zone that's at risk. And this infarct that takes place is killing this tissue because there's no distal blood flow from that This is the left anterior descending artery, LAD, I believe. Yeah, left anterior descending, right there. Okay, left anterior. So this should be the circumflex that comes off here, left circ, and this is the LAD. So if I blow up this region and I take a look at 0 hour, 2 hour, and then 1 day later, the area that is supposed to be perfused by the blood that's furthest away from the vessel of the artery that's obstructed is the endocardial region. So the first tissue that becomes necrotic is the endocardial region of the heart. That involves some myocardium, but it's the inner layer. Okay? And then it spreads transmurally. So the wave front moves from subendocardial, just beneath the endocardium. You can see the area at 2 hours is into the myocardium, but it's on the subendocardial side. By 24 hours, it's all the way through, which is a word we call transmural, all the way through the wall. So as long as you treat within the first couple of hours, you don't wait a whole day to treat and reopen up that lesion, you may not have a necrotic zone that's all the way through the heart wall. Make sense? All right, so how do we determine clinically that maybe we have a patient that had a heart attack? If you can't see angiography-wise. Well, you can also measure some things in the blood. And I want to show you these pictures. Let me dim the lights. So this is obviously post-mortem. The patient didn't get the heart back after we cut it. But you can see the heart. This is the left ventricle on this side. This is the right ventricle. And the area that's at risk is all of this tissue. Do you see all of this whiter colored tissue here? And all the darker colored tissue is quote-unquote normal, if you will. Okay? And so if you look here, you can see that it's all of the subendocardial tissue at higher mag, all of this tissue here around the left ventricle that actually died. Okay? But it was a large enough region, it surrounded, 65–70% of the left ventricle that the patient didn't make it. It wasn't even transmural. Transmural, this dead tissue would go all the way through to the edge. Make sense? So obviously this heart attack happened within that first couple of hours, like this previous picture shows. You with me? So what do we look at blood-wise? Well, we can do some blood measurements, and we can look at some leaked proteins that might be present there. So for example, troponin. Remind me what troponin does. What does troponin do, generally?
Blocks the binding site.
Troponin.
Does it activate tropomyosin? So
it's bound to tropomyosin. Calcium binds to troponin, right? The TNC side. Okay. Oh, some of you are like, ooh, whoops. Right. So it's involved in blocking the binding site because it's linked to tropomyosin. Calcium binds to TNC. Okay. Well, when you have an infarct of cardiac tissue, that linkage of troponin to tropomyosin is not super strong. So you get a lot of leakage of damaged troponin. So you'll detect TNI and TNT in the bloodstream. All right? TNI and TNT appear 2 to 4 hours after an infarct. They peak at 48 hours, 48 hours they peak, and they'll remain elevated in a patient for a week to 10 days. So if a patient says, you know what, I think I had a heart attack, you measure blood levels and you can almost confirm if they had a heart attack or how big the infarct was just based off of blood analysis. Another one is creatine kinase myocardial bound, CKMB. CKMB, this rises in 2 to 4 hours. It peaks about 24 to 48, but it's gone by 72 hours after an infarct. CKMB is an indication of damage to the heart muscle itself, right? Because the creatine kinase that's supposed to be bound to the myocardial tissue is freely disassociated because that tissue is damaged. Then the last marker in the bloodstream that you can measure is called LDH, lactic dehydrogenase. So what does this one do? LDH indicates what? That glycolysis was an energy source that the heart was trying to use. So if lactic dehydrogenase levels go up and are elevated, then you would expect to see a myocardial infarction. Because the heart likes to operate on aerobic sources of ATP exclusively, right? It's a long-term exercise that the heart's doing, right? Hopefully 70, 80 years of exercise. So it uses aerobic metabolism to generate ATP. So if lactic dehydrogenase levels spike above normal, that tells you that there was a last-ditch effort to try to generate energy to keep the heart alive. Okay? So what kind of complications could arise from a heart attack, myocardial infarction? Well, we could get arrhythmias. We could disrupt our electrical signaling of the heart. We could have dysfunction of the contractile elements. We could actually have a myocardial aneurysm or a rupture. The heart could aneurysm out, be compromised. Or we could have a mural thrombus. This is a picture of a mural thrombus right here. You've got a tear right here that's happened in the wall of the heart because the damage to that tissue was so extensive it weakened it and it's pressurized so it can't handle the pressure. Progressive heart failure. So ischemic heart disease could be the stimulus that causes damage to a region of the heart, and then slowly over time, if the patient survives, they may start developing symptoms of heart failure. CHF, congestive heart failure. Okay? Questions? So what I want to encourage you guys to do